All right, so I'm recording this session even though we're doing it live because the other one kind of went corrupt on there, and I will have this posted for you. The next endocrine structure that we're going to talk about is your pancreas. Your pancreas has both an endocrine function as well as an exocrine function to it. So if it means it has an exocrine function, you won't talk about that until AMP2. When we start to talk about digestive enzymes that are required for the chemical aspect of digestion, you have pancreatic lipase, pancreatic amylase, all these different sorts of, and if it ends in ASE, what does that tell you? It's an enzyme. So you have all these enzymes that are meant to aid digestion. That's the exocrine function of the pancreas gland. Since we're in the endocrine chapter, surprise, surprise, we're going to talk about the endocrine function of the pancreatic gland. And when you think of the pancreas and you think of hormones, what hormones usually come to mind? Insulin, absolutely right. Insulin and glucagon. Insulin and glucagon kind of work antagonistically with one another, where insulin, does it raise or lower your blood sugar levels? It lowers your blood sugar levels, so glucagon would do the opposite of that. It would raise your blood sugar levels. So anatomically speaking, where you'd find your pancreas, it kind of lies at the bottom of your stomach and right next to the first part of your small intestine called the duodenum. So the endocrine glands of the pancreas, they consist of cells that form what we call pancreatic islets. You have alpha cells and you have beta cells. So I'm going to start pointing at these things because I think they're pretty important to remember. The alpha cells are going to produce the glucagon, and from what you all just told me a second ago, glucagon's job is to do what to blood sugar levels? Raise them or lower them? Raise them. Can you think of any point in time when your blood sugar levels might be low? When you're exercising, if you haven't eaten enough, those are all examples of when your blood sugar levels are going to be low. You store glycogen in your liver and you store it in your muscle cells. You probably remember that from our muscle chapter. So if your sympathetic nervous system kicks in, a bear walks into the room, and our illustrious men decide they're going to fight the bear while we women run away from it, their glucagon reserves are going to kick in. We're going to mobilize all their glucose so that they can have energy to fight the bear as the rest of us flee away. So glucagon, and actually glucagon and insulin use, they're kind of always being released from your pancreas all day. Now, people who are diabetic, they usually have a little bit difficult time maintaining their glucose levels. And that's for a couple of different reasons. One, they might not make enough insulin, or two, they might not their body is just no longer sensitive to their insulin. They have insulin insensitivity. So beta cells produce the insulin, the alpha cells produce the glucagon, delta cells produce a peptide hormone for growth hormone, which we don't really talk about a whole lot, and pancreatic polypeptide is produced by the F cells. The two cells I want to make sure that you do remember, because we're going to talk about them for the rest of this chapter, are the alpha and the beta cells. So obviously, when blood levels rise, beta cells release insulin, and that stimulates the transport of glucose across the plasma membrane. The way that glucose works is it's basically like a key. Each one of your cells has a receptor on the outside of it, and in order for it to take in food, to take in glucose, to take in any of these macromolecules or subunits of macromolecules, it requires insulin or a key to fit on top of it. So insulin allows the cells to take glucose in. So you can clearly see why if someone is diabetic, if they don't have enough insulin, they don't have enough keys to open up those cells, then if we were to test their blood sugar level, because their cells are literally starving themselves, you have really high blood sugar levels on there. There are different types of diabetes. The most common are juvenile onset or type 1, type 2 diabetes, which they traditionally call adult onset. And does anyone know what the third type of diabetes is? Gestational diabetes for pregnant women. So there are some pregnant women, and the older you get, by the time you're 35, if you haven't had a child yet, they consider you a geriatric pregnancy. I know, right? 35 is not old or geriatric in my opinion, but you're more likely to develop gestational diabetes the older you are, or if you have a history of diabetes in your family. Because there are some younger women, which, 25 is still just a baby, but there are some younger women that are pregnant and they develop gestational diabetes as well. Temporary during pregnancy, absolutely right. In fact, as soon as you deliver, your body goes back to normal. Once you get that little parasite, as cute and cuddly and warm and fuzzy as it is, once you get that parasite out of you, your body goes back to normal. With my last pregnancy, I had gestational diabetes, and I was really upset because I worked out, I ate well, and I just didn't understand why this was happening to me. But when I delivered her, I was 35, a geriatric pregnancy. But as soon as she was born, my blood sugar levels went right back to normal. Alpha cells, on the other hand, do the opposite. They're going to stimulate glucose release by the liver, so to bring those blood sugar levels up. What are some problems you think you can have if your blood sugar levels get too low? How do you feel when your blood sugar levels get too low? Tired, weak, grumpy, hangry is what my daughter calls it. You're hungry and angry. Yes. Yes, exactly. So it's very important to make sure that we have our blood sugar levels stabilized. So insulin is a peptide hormone that's released by your beta cells. So see, that keeps coming up again, so make sure that you remember that. The way that it targets your affected cells, it accelerates the cell's ability to take up glucose. It accelerates your body's ability to use glucose and make energy from it. As you remember from micro or introductory biology, that the starting material for cellular respiration is that 6-carbon sugar of glucose, and it makes energy, or ATP. It can also stimulate your cells to form glycogen. Glycogen is just a long polysaccharide that's nothing but a bunch of glucose stuck together. It stimulates amino acid absorption. When you see amino acids, what macromolecule do you think about? Amino acids make proteins on there. So stimulates amino acid absorption and protein synthesis, all of which are needed by your body to carry out its normal daily functions. And it even stimulates triglyceride formation in adipose tissues. Triglycerides are like your dietary fats that hang out in your fat cells, and those are also used for energy. Glucagon, once again released by the alpha cells, will mobilize those energy reserves. One reason we talked about those energy reserves being mobilized is because if your sympathetic nervous system kicks in, we need it to be mobilized when you're exercising or working out. So those are all reasons we want to have a lot of energy. The way the target cells are affected by this hormone is that it stimulates the breakdown of glycogen in your skeletal muscle cells as well as in your liver cells. It breaks down triglycerides in your adipose tissue. Fats have a lot of energy in them. So when glucagon is released, those fat cells, the way they respond is by mobilizing those triglycerides and turning them into energy. And it also stimulates the production of glucose in the liver. All of these things are done just to fulfill one goal, and that's to do what? Raise your blood sugar level. Absolutely right. To raise the amount of glucose that's available for your cells. So on to diabetes. We've kind of talked about this already. Diabetes mellitus is characterized by glucose concentrations that are high enough to kind of overwhelm the kidneys of what they need to do. If diabetes is untreated, is not well managed and untreated, there are lots of different things that can happen. Something as severe as your retina being detached because the capillaries will burst in your retina, to even losing a limb, losing sensation in your extremities if you don't manage your diabetes. For gestational diabetes, one of the things they really worry about is that when it's time to birth your child, that your child may have shoulder dysplasia, because we go from having a nice average 7 to 8 pounder to the baby being maybe 10 or 12 pounds and just too big to pass through the shoulder, the birth canal. So their little heads, which should come through first, they're just so big that one shoulder may get out and the other one doesn't. And if we have that happen, then there's a chance that the baby suffocates and doesn't get enough oxygen. Because as soon as the placenta pulls away from the mom's no longer giving baby oxygen. So once that placenta pulls away from the mom's uterus, we have to make sure that baby gets oxygen. These days, because most women that have gestational diabetes manage it properly, either with insulin or with exercise and with a change in their diet, and also with the medical advances we have, sometimes they have to break baby's shoulders to get baby out. We don't see a whole lot of infants die as a result of shoulder dysplasia, but there have been lots of complications with moms and babies before. Hyperglycemia, high blood sugar, anytime we see your glucose appear in the urine and your urine volume becomes really excessive, that's one of the first hallmarks or symptoms of diabetes. We consider that polyuria. So type 1 diabetes used to be called juvenile onset diabetes because we mostly saw this begin in juveniles. We've seen children as young as 7 develop type 1 diabetes, and we've seen older teens as old as 19 be perfectly healthy all their life, and then all of a sudden they just develop type 1 diabetes. This type of diabetes, we are pretty sure it doesn't have much to do with environment. It's more genetic. You're just genetically predisposed to developing this type of diabetes. We call it insulin dependent because these folks just don't make enough insulin to cover what they're just normally eating. Persons with type 1 diabetes require insulin to live, and they usually have to give themselves multiple injections throughout the day, or they can use a pump, and you may have seen some people at school or at work that have a pump that just kind of gives them daily injections of it. A couple of drawbacks to the pump, they're really awesome and really cool, and people that have the pump manage their diabetes well, is that it's kind of expensive. It's kind of a pricey device, and not everyone's insurance will cover the pump, and I don't know how, like, the Obamacare insurance, if they would cover the pump or if they would just cover the good old-fashioned injections. Injections, can you imagine trying to give injections to like a 6 or 7-year-old and having to do that for them, that it really is kind of a learning curve for them to have to do. So that's why the pump is usually preferred. This form of diabetes accounts for only about 5% of the cases of diabetes, this type 1. 10% of those cases, most of them develop in childhood or early adulthood, like 19, 24. We'll see people develop type 1 diabetes. Type 2 diabetes is non-insulin dependent. Most of these people have normal amounts of insulin at first, but their tissues stop responding to the insulin they have, and it means that their tissues now have insulin resistance. This is a diabetes we mostly associate with obesity. Type 2 diabetes does not always require insulin. Diet and exercise have proven to be very adequate treatments for type 2 diabetes. It's the same with gestational diabetes. With my gestational diabetes, I was determined not to be on insulin, so I just made sure I walked for 60 minutes every day. If I had a slice of birthday cake, I'd have the tiniest slice I can have, then I'd go walk for 30 minutes to try to burn that sugar off as quickly as I could. So changes in your diet and exercise are great treatments for this type of diabetes. The reason obesity is associated with this is because it's believed that the overabundance of sugar in our diet, especially in the U.S., think about what you had for breakfast. Probably 90% of it was carbohydrates. What are carbohydrates? Sugars. And that's just our diet that we have, especially in the hardy Midwest. We have a very carb-based diet. And a lot of people, if you're eating so much of this, your body just becomes insensitive to the amount of insulin that you're making, and you're consuming more carbohydrates or sugars than your body has enough insulin to cover. But as I said before, weight loss and diet can definitely be an effective treatment. If you don't manage your diabetes properly, things that can happen: kidney degeneration, retinal damage, actually going blind as a result of your retina detaching, early heart attacks, peripheral nerve damage, and peripheral nerve problems where you're no longer feeling sensation. Part of the reason that I probably developed gestational diabetes is not only because I'm old, but also because I have a history of diabetes in my family. That I have an aunt with type 1 diabetes. She didn't develop type 1 diabetes until after the birth of her last child. She had him when she was 40, and about 45, when he was 5 years old, she developed type 1 diabetes. I also have an uncle that has type 1 diabetes, and I have another aunt that's got type 2 diabetes. And we're not an obese or overweight family. That's just kind of how our genes roll. So there's a pretty good chance that at some point in my life I may develop type 1 diabetes. For my uncle that had type 2 diabetes, he started off not managing it because he didn't think that it was super important, and he thought, oh, they don't know what they're talking about, I feel absolutely fine, until he lost his foot. So it started off with an ulcer on his foot that just would not heal. He would lie to my aunts and my grandmother about, why he was limping, and by the time he finally went to a doctor, all of his toes were black. So at that point, they had to go ahead and just take the foot. Yes, sir. Yes. Yes, it does. It's aggressive, exactly. And that's what it was for my uncle. It was about 6 to 8 months after he was given his diagnosis, and he was like, there's nothing wrong with me. I don't know what they're talking about. It's just pharmaceutical companies trying to make money off of us. And he lost his foot. He manages it well now, so after he lost his foot. But it does not take very long. It goes very fast. Diabetic neuropathy is a degenerative change in the kidney, can lead to kidney failure, where the nephrons, the actual parts of your kidney that are meant to filter out your blood, they're not working properly, so that leads to that kidney failure that we talked about. Retinal damage, diabetic retinopathy, the capillaries start to hemorrhage and causes the retina to detach and can cause partial or complete blindness. Early onset heart attacks, we just talked about. Peripheral nerve problems, the blood flow to the neural tissues is no longer what it should be, and it can cause diabetic neuropathy. So the actual sensation would be lost. As for my uncle, he completely lost sensation in his foot, and that's why when the ulcers were starting to get really, really bad, he would just wear 2 pairs of socks so that his wife wouldn't notice it, and he would change his socks all throughout the day. And then finally she just noticed, like, something really smells bad. Well, that was the necrotic tissue of his toes. His toes were dead. So at that point, if he had managed it properly, he would have kept his foot, and probably much the same way with your uncle, he probably would have kept his life if just properly managing it. We've kind of talked about this already. The distal portion of the limbs are reduced, and so the blood flow to the feet can lead to tissue death, ulceration, infection, loss of toes, or both feet. All right, on to other endocrine tissues. So the remainder of these structures that we talk about are not necessarily endocrine tissues, but they have an endocrine function. So you'll see these, we'll discuss them again in A&P2. So your intestines have their own hormones like VIP and CCK that help to regulate digestion. Your kidneys are not an endocrine structure, if you will, but they do produce pretty important hormones, erythropoietin and calcitarol. Erythropoietin's job is to make red blood cells. Renin's job is to kind of raise blood pressure. It activates angiotensin II. The heart makes what we call natriuretic peptides. These natriuretic peptides oppose angiotensin II, so they help to bring down the blood volume and blood pressure. And the way that they do that is they reduce the blood volume. And anytime your blood volume gets high, then think about there's more blood that's running through those vessels, then the pressure that hits the wall of those blood vessels is also going to increase. So with angiotensin II, if your blood pressure is too low, then there are things that can happen and take place. We'll add more water, we'll conserve more water to increase the blood volume. We can increase the blood volume, we can increase the pressure. If your blood pressure is too high, that's where we have these natriuretic peptides can come in to try to reduce the level of volume, increase the amount of water that you lose to your kidneys to bring down the volume and the pressure. And that whole discussion we're going to talk about again in A&P2. Thymus gland produces thymic hormones, help to develop and maintain normal immune defenses, specifically T3 and T4. Your testes, if you're unfortunate enough to have them, sorry, little joke there, produce androgens and interstitial cells. Testosterone is the most important male hormone. Without it, males would not have their secondary sex characteristics, so more muscular males on average. I know it's very unfair. They have a lot less body fat than we do. They can work out for 2 weeks and get chiseled, and it will take us 1.5 years because they just have less body fat and they build muscle very quickly because of testosterone. Inhibin, which is secreted by their nerve cells, helps to support and to nourish the developing sperm. And this is a discussion, it's just kind of an introduction into the hormones, because we'll talk about that whole process of sperm maturation and differentiation in A&P2. Ovaries, if you're fortunate enough to have those, produce estrogens. After ovulation, the follicle cells leave kind of a scar tissue called the corpus luteum, and it makes that progesterone. And once again, we'll have a much more in-depth discussion in A&P2. Adipose tissue will also make some of its own hormones, leptin and resistin. Leptin is a feedback control for appetite. Resistin reduces insulin sensitivity on there. And the way that hormones interact with one another is that they can have opposing effects like insulin and glucagon. One increases blood sugar level, one decreases blood sugar level. They can have synergistic effects to them. So a synergistic effect would be that they kind of, the additive effects to it overall. So in the case of antidiuretic hormone and erythropoietin, let's say that your blood volume is very low and your blood pressure is low, your kidneys can be stimulated to produce erythropoietin, which will cause you to make more red blood cells. The more red blood cells you have in your blood, that increases your blood volume, so that's going to increase your blood pressure. So erythropoietin is working along with kind of another hormone, antidiuretic hormone, that helps to retain the amount of water that you keep in your body, all in an attempt to raise your blood pressure and your blood volume. We have permissive effects, like with releasing hormone released from your pituitary gland that tells your, releasing hormone from your hypothalamus that tells your pituitary gland to release melanin-stimulating hormone or oxytocin or any of those hormones that are released from the pituitary gland. And then you have kind of integrative effects. At any point in time, you don't just have one hormone that's circulating. So you have multiple hormones that are circulating doing very different things. So for a cell in your kidney, the hormone of insulin is released. It gets into that kidney cell. It allows that kidney cell to have energy to release its own hormone of erythropoietin or renin to increase the blood pressure. So it's just kind of this hormonal interaction slide is just meant to sort of show you that there are different ways these hormones can interact with one another, and at any point in time, the concentration of your hormones can be varied. Growth hormone supports in children, specifically skeletal and muscle development. In adults, it helps us to maintain our blood glucose levels. And early research has shown that if you have a regimen of growth hormone, and not just a growth hormone you find at CVS or at Walmart, but like legitimate growth hormone, which is probably about a $10,000 a year habit, it actually helps. It's supposed to increase your lifespan. So I had a professor when I was in grad school that he and his wife were 87 years old at the time. They were both taking growth hormone. He was a professor of the biology of aging, and he swears that it's increased their longevity and their ability to do things like ski and hike and do all that good stuff there. There are some extreme athletes that use growth hormone to help to maintain their blood glucose levels and to maintain their level of activity. But growth hormones, to get a prescription for growth hormones is kind of pricey. So it's about $10,000 a year to get the real stuff. Now at Walmart and CVS, they'll sell you something that says it's growth hormone on the side of it, but it's got like a bunch of other crap in it. There's no growth hormone in it at all. Thyroid hormones, if they are not present during fetal development or in the first year, the nervous system will not develop properly, and it can lead to mental retardation or developmental delays. If T4 concentrations decline before puberty, then the skeletal system will not continue to properly develop. We've talked about insulin, how its job is to allow the passage of glucose and amino acids to the plasma membrane. Parathyroid hormone and calciferol, they also work antagonistically with one another, where parathyroid hormone is going to increase your blood calcium levels, and calcitonin is going to deposit calcium into your bones. If you don't have adequate levels of parathyroid or calciferol, then the bones can become very weak and very flexible. Reproductive hormones, androgens in males, estrogens in females. Ladies, we do make some androgens because we have some from our adrenal gland, but it's a very small amount compared to males. They stimulate the growth and differentiation of target tissue, so depending on how much estrogen you have or how much testosterone you have, those are the secondary sex characteristics that come out. The skeletal proportion changes, the muscular mass, fat deposition and distribution changes we see between males and females. And then hormone changes, as we noted with the thyroid hormones, that if you don't have enough of those in fetal development within the first year, it can cause developmental delays and issues with learning, memory, and the capability to learn. They can affect the behavior when endocrine glands are over-secreting or under-secreting. And aging causes a couple of functional changes that happen within the body. You definitely have a decrease in your growth hormone as you get older, as well as a decrease in your reproductive hormones. All right, so that is the end of that chapter. Now we're going to go on to the first portion of the brain and the reflexes. Uh-oh, I have to close that. And this last set of notes is really like 3 different chapters sort of rolled into one set of notes. So I don't go over everything in the chapter. I just kind of hit the highlights. So very good question. I have page numbers in these notes. They don't correspond to your textbook exactly, but they're kind of close enough in there. I know one chapter is chapter 14, one is 15, and I'm not sure exactly where reflexes are, but it might be somewhere in there. So pages 436 to 443, which are not the page numbers for the new textbooks, but I think they're close enough that you can kind of figure out where they are. Spinal reflexes, most of your reflexes are actually found in your spinal cord. You don't even have to send that information to your brain to get a response out of that. They're rapid, automatic, and they're triggered by specific stimuli. One reflex you're probably very familiar with is the knee-jerk reflex. So when you go to the doctor's office, they tap that patellar ligament there, and it causes your leg to jump out. So that's a reflex that you're probably all very familiar with. Nerve plexes are just divided as complex interwoven networks of nerve tissues or fibers. You have various different nerve plexes throughout your body, and they control skeletal muscles, the neck and the limbs, and they kind of are these where in your spinal cord you have a dorsal aspect to it and a ventral aspect to it. So where the spinal nerves come out of the front and the back of it, and they meet together, they form these plexes. One clinical note that's considering nerve plexus is that once you have chickenpox, there is a possibility of the virus, the varicella zoster virus, like dormant on just one nerve plex. So if you've ever had chickenpox, you notice that you have little pox spots all over your body, but if it comes back when your immune system is compromised as shingles, it doesn't come back all over your body. It only comes back on whatever nerve plexus that it was lying dormant. 4 major nerve plexes of the ventral mammary that I want you to know are cervical, brachial, lumbar, and sacral. And by looking at the nerve plexes, you can kind of figure out about what part of the body that they innervate. So when you think cervical, where's your cervical region? Neck region. So where do you think these nerves would kind of innervate? Anything of the neck and the face, any of those there, and most of them actually from the neck is just kind of the neck and the shoulders. Brachial, where's your brachial region? So out towards your chest, top part of your arm, this is your brachial, so all of this area here. Lumbar, where would that be? Middle portion of it, and then your sacral plexus, down there a little bit lower, good. Reflexes are automatic responses that are coordinated within the spinal cord. What reflexes do, you can have a simple reflex. That means there's just one synapse. The motor neuron talks directly to the sensory neuron, and it gives you that response. Or you can have the motor neuron interface with the interneuron in the spinal cord, and then that interneuron tells the motor neuron what to do next. So for example, something that if you touch something very painful, like you prick your finger on a pen, what do? You leave your finger there. You withdraw it away. You withdraw it back from a reflex. And you don't even think about it. It's just you prick something out and you pull your finger back. So that sensory information of pricking your finger is going to go just to your spinal cord. It doesn't even have to be processed by your brain. And then it sends that information to the motor neurons that say, pull your finger back. Simple reflexes, just one synapse. Complex reflexes would be that if you're walking along and you step on a tack, there are lots of things that have to happen. First, you're walking along, you step on a tack, you withdraw your foot that stepped on the tack. Now, when withdrawing your foot that stepped on the tack, what do you have to do with your body weight? You got to shift it over onto the other leg, because if you don't, what are you going to do? You're going to fall over. So you have to shift it over to the other leg. So not only do you have to have the contraction of the quadricep muscles and then the relaxation of the hamstring muscles to withdraw your foot that stepped on the tack, but then you're also going to have the contraction of your quadricep muscles in your standing leg. So that's what we call kind of a cross reflex. It's a much more complex. So withdrawal reflexes, or if somebody throws something at you, what is your reflex? Do you know what it is if someone throws something? You blink. So you're getting, well, you said you catch it. That's what my son said. So my son is 11, and he plays catch, if you will. It's a little soft, cushy kind of ball with the 13-month-old. Now, the 13-month-old hasn't learned to catch yet. So he throws a ball at her, and he hits her in the face, and she just cracks up laughing. It's all fun. He's like, why isn't she catching the ball? And I said, well, she's 13 months old. She hasn't learned to catch the ball. So that's a great example. It's a reflex for people like Rob. Did you play baseball growing up, or football and that kind of stuff? You had a lot of balls flying at your face, and if you didn't want your nose or your eye socket to be broken, you learned to do what? Put your hands up and catch it. So it's more of a learned type of reflex. So now for Rob, it's a reflex. But for Eliana, not a reflex. It's just getting popped in the face. Now, if something comes at you, blinking is a reflex. Even if you go to a 3D movie, if something looks like it's coming out towards you, blinking is a reflex for that. That's the innate thing to do. Catching is more of a learned sort of activity. So now Eliana has learned to kind of put her hands up. She doesn't catch it, but she'll at least protect her little face. She's kind of learned that process. But sometimes I think she just likes to be hit in the face because it's fun. I don't know what's wrong with children. Neural reflexes, once again, are automatic. You have a reflex arc. Make sure this is a great possible question for a short answer question. It's the wiring of a single reflex begins at the receptor, which is going to detect what the stimuli is. This is something hot. This is something pokey. This is something painful. So it begins with that receptor, and then it ends at the effector. And the effector is the muscle or the gland that's going to respond as a result of the stimuli. So if you touch something hot, the normal, healthy response is to withdraw your hand away from whatever that hot thing is. So the receptors pick up the sensation, this is hot, and then the withdrawing of your hand away, that's the effector that's saying to pull your hand away. So generally, it opposes the original stimulus. Hot thing, pull hand away from it. Pokey thing, pull hand away from it. We don't have very many, and I can't think of any reflexes that would tell you to go forward or it doesn't oppose the original stimulus. So the 5 steps in developing a neural reflex: first, the stimulus has to arrive at the receptor, so some sort of physical or chemical change. Something's hot, something's pokey, something's painful, it's uncomfortable. Activation of that sensory neuron develops a greater potential, which means that that neuron that senses that sensation is sending that information via synaptic transmission. The information is processed by the postsynaptic cells, which is triggered by the neurotransmitters that are released from the original receptor neurons. They release these neurotransmitters and tell that postsynaptic cell, hey, this is how we need to respond. And then in the same way, coming out from the spinal cord, we need an action potential that goes out towards the effector. And the response of that peripheral effector, so if it's a muscle in this case, and we need the arm to contract the muscles to withdraw the hand back, acetylcholine would be the neurotransmitter that's released in order to withdraw or oppose that stimulus. So great short answer question, these 5 steps to the neural reflex. And I might give you an example, explain the 5 steps to the neural reflex when you touch a hot stove. So just be able to tell me that what the receptors are, what the effectors are, where do we see action potentials in both the sensory neurons as well as in the motor neurons. So innate reflexes are those are very basic. You're born with them, and many of them are formed before birth. So the rooting reflex, and if you have children or pets, small pets or farm animals you're taking care of, what's a rooting reflex? Right, for nursing. So if you brush a baby's cheek, they turn towards whatever cheek you're brushing. And then the way you want to do is they'll suck on it. If you put your finger in a baby's mouth, and I do not recommend doing that because your hands are filthy, but they're going to suck it. They put everything in their mouth. So that sucking reflex is something they actually do before birth. The whole when something comes in your face to blink is something that you do before birth. So those are basic neural reflexes. What's another good neural reflex on there? The clenching of your fists for babies. They will clench their little fist up if you tickle them, and they kind of ball up in a nice little tight ball. That's all a basic neural reflex. And sometimes, and I still kind of sleep in the fetal position because it's comfortable for me, but it's kind of a basic reflex. It's where I feel most comfortable. Acquired reflexes are kind of what Rob talked about because he was an athlete and he learned through this motor pattern that if something is coming towards you, you put your hand up and you catch it. That's something you kind of have to learn. Walking, driving. Is there anyone in here who does not drive? So right now, driving is a reflex for you because when you're turning, well, I turn on my turn signal. If I'm making a turn, it's a reflex to turn on that turn signal because my dad would always yell if I didn't, people don't know what the hell you want to do. So if I didn't turn my turn signal on, it's the reflex for me. Walking is a reflex. Riding a bicycle is a reflex once you've learned to do it. It's more of a learned motor behavior at this point because you have to learn it first. The nature of resulting motor responses, we have somatic reflexes and visceral ones. Whenever you see somatic, I want you to think about muscles being involved. So somatic, and that's not just true for this chapter, but for everything that we've talked about and that you will talk about in AMP2, somatic usually involves some muscles, so expect some muscles to be involved. Visceral involves something internal, so any of your internal organs, stomach, liver, pancreas, uterus, if you've got it, vas deferens, if you have those. So all of those would be considered anything else other than the muscular system. So somatic reflexes, you do have some involuntary control over the nervous system. Great example of a somatic reflex is the knee jerk reflex where they tap that patellar ligament and then your knee jumps out. What happens there is that there is a bank of sensory nerves right behind that patellar ligament, that when they hit it with a little rubber hammer, it presses those sensory nerves. It sends the information to your spinal cord through the sensory or the afferent division, and then the motor neurons come to your quadricep muscles, cause those quadricep muscles to contract. When the quadricep muscles contract, the lower leg is going to lift up. Yes, sir. Right. Spinal cord, absolutely right. Right, it's all just a spinal cord thing. And even like a withdrawal reflex, a lot of times you'll touch something that's hot, you'll pull your hand away and say, whew, that was hot. So you've already pulled your hand away by the time your brain's had a chance to process what happened. So yes, a lot of those reflexes, especially your innate reflexes, knee jerk, rooting, even sucking as a reflex for babies, it does not even have to go to your brain, it goes to your spinal cord. Absolutely right. So spinal reflexes occur in the spinal cord, and a majority of them happen and are processed in your spinal cord, and cranial reflexes happen in your brain. Spinal reflexes can just have one synapse. Those are the most simple monosynaptic reflexes. The most complex are, well, the next complex are polysynaptic reflexes. And intersegmental reflex arcs are very complex reflexes. So that's walking along, stepping on a tack. You have those crossed sensors that take place, so it's a kind of a cross-receptor sensor sort of mechanism. Walk along, step on a tack, gotta put all the weight on the other leg and so forth. So it gives you a much more variable motor response. So monosynaptic reflexes, the patellar reflex is a good example of that. They are complete within 20 to 40 milliseconds, and the receptor is a muscle spindle bundle. There's just one synapse there. Sensory neuron talks directly to the motor neuron, so that's why it's a very simple reflex, that knee-jerk response. Thank you. Pretty picture of all that happening. It's a little rubber hammer. It hits you right there on the patellar ligament. The stretch receptors are then going to send that information to the spinal cord. Notice that the red one is a sensory neuron, the black one is a motor neuron. So the sensation of I've been hit goes into the spinal cord, and we only have one synapse there. So then at this point, I've been hit, do something about it. The motor neuron says, I'll do something about it, all right. And it causes the effectors, which are the muscles that are now going to contract, and that's what brings your lower leg up. This is considered a monosynaptic reflex for one reason, because it only has one synapse. Sensory neuron talks directly to the motor neuron. There's no middleman here. For a polysynaptic reflex, how many synapses do you think we have to be working with? More than one, so at least two. So we got to have at least two there. Withdrawal reflexes move the body away from stimulus, and usually pain or pressure, anything that's an unfavorable stimulus. Flexor reflexes are a good example of that because you have to flex or decrease the bond angle. You're touching something that's hot. When you withdraw your hand away, this angle, which is at 180 degrees when my arm is straight, is now reduced to probably, 80 degrees when I bend it, so that's why it's called a flexor reflex. The strength and the extent of the response depends on a couple of things: the intensity of the stimulus and also the location of the stimulus. Your hands, if you remember, have 5 layers of skin on them because they're meant to deal with more rough abrasions and more things being hot. So the time it takes for those sensations to reach your spinal cord and withdraw your hand away when the palm of your hand touches hot is going to be a little bit longer, not much, we're talking milliseconds here, than if the back of your hand touches something that is really hot, or your cheek has something really hot that's on it, because you have fewer layers of skin and they're much more sensitive. So pretty picture of this reflex here. Painful stimulus, we've reached out towards it. We're going to decrease that bond angle. Notice that our sensory neuron, how many synapses do you see here? Do you just see one synapse? No, we have one here, we have one here, we have one here, and we have one there. So the sensory neuron is now going to talk to these interneurons that are in the spinal cord. The interneurons are going to do a couple of things. One, they're going to relay the information to the brain. We just touched something hot. The next thing that it's going to do, well, and this is happening simultaneously, if you will, is that it tells the arm that you need to contract yourself, the effectors, to withdraw yourself away. Now, you can't have your muscles in your arms and in your legs primarily work antagonistically with one another. As one contracts, the other one needs to do what? Relax, because if they both contract at the same time, can I move my arm away? No, my triceps and my biceps are both contracted, and I'm just stuck holding on to this can. So in order for me to reduce that bond angle, 2 things have to happen. Biceps are going to have to contract, so they have to get the message to contract, and then your triceps are going to have to be inhibited. So the message from the brain comes back down, and the interneuron is then going to have the extensors or the other side of the muscle to be inhibited so that you can pull your arm away so that it's not contracted. Cross-extensor reflexes are those reflexes we talked about that when you're walking, you have to kind of pull your leg up and shift your body weight to maintain those reverberating circuits. This is not an innate reflex. This is kind of something you have to learn. My little 13-month-old Eliana, she just started walking a couple of months ago, and a few weeks ago she stepped on one of my son's Legos, and so she drew her foot back, but she didn't stay balanced. She just fell over. So her whole little body just fell to the ground, and my husband's like, I don't know what happened to her. She was walking along fine. It was just like somebody sniped her out of nowhere. But she couldn't withhold her body weight, so she pulled her leg back and just toppled over and fell on the ground. So for these cross-extensor reflexes, there's a lot of different things that have to happen. You have to be able to withdraw your foot, balance the weight on one leg. The muscles are going to have to tense on one leg, and then your quadricep muscles have to contract, and your hamstring muscles are going to have to relax to withdraw that leg away. And once again, nice picture of that. Also example of a polysynaptic reflex, but this is one of those intersegmental reflex arcs that the sensory neurons come in, they talk to the interneuron, send information to the brain, and then not only do you have to send information to the leg that's directly affected by stepping on the tack, but you also have to send information to the other leg that's maintaining the weight. Voluntary movements and reflex motor patterns, higher screens of the brain are incorporated, as we saw with the cross extensor reflexes on there. The brain can be used and activated as needed. Walking, running, jumping. If you're walking along and you see something right in front of you 2 seconds before you, it is kind of a repetitive sort of reflex, and your brain kind of alters that reflex of walking a bit that you'll step over it. So if there's a puddle or something gross in the middle of the floor, you kind of have this ability that your brain can alter the reflex of that learned motor pattern of just stepping and stepping along. Another example is that, Devin, I'm guessing you played sports and all that other crap too, so that reflex of, does it serve you well to play baseball, and the reflex of closing your eyes when something comes towards you? Does that really serve you well? No. So your brain, you've been taught to overcome that reflex of putting your hands up and keeping your eye on the ball, watching the ball hit your mitt, watching the ball hit your bat. It's funny to watch my mom, who has not an athletic bone in her body. She played in a charity softball game this summer, and she closed her eyes every time she swung the bat. I said, you're never going to hit anything if you don't watch the ball. But she never learned to play baseball or to watch the ball, so her brain never learned to overcompensate or overcome that natural reflex to close your eyes when something comes towards you. All right, and that's the end of it. The remainder of this is on the last lecture, and I'll have those all put up on YouTube this afternoon, definitely. I think we might have one up there unless YouTube didn't take it, because I had problems with Blackboard. Questions, comments, or concerns?